So, welcome everyone. It's a pleasure for me to open up our officially very first lecture in this academic year in the Women's Wellbeing Lecture Series. And this series is made possible because of the generous support of Dr. Rosemary Bowes, PhD, who is an assistant clinical professor in the Department of Psychiatry and Behavioral Sciences and Obstetric and Gynecology in the GW School of Medicine and Health Sciences. And today I am privileged to welcome our guest speaker. And this is Dr. Neustadt. Dr. Neustadt, ND, was the founder and a medical director of Montana Integrative Medicine and is a founder and president of the dietary supplement company Nutritional Biochemistry Inc., or NBI, and of the NBI Pharmaceuticals. Dr. Neustadt started NBI in 2006 when he couldn't find products with the doses or combination of nutrients shown in clinical trials to work, and that he needed to help his patient. Since then, NBI has shipped its products to people in more than 15 countries around the world. Through NBI Pharmaceuticals, Dr. Neustadt received more than a dozen US FDA orphan drug designations for potentially treating rare diseases using natural products. He hosts the Delivering Health podcast. He is also a member of the Bone Health and Osteoporosis Foundation Corporate Advisory Roundtable and is a vice president and treasurer of the California Naturopathic Doctors Association. Dr. Neustadt was co-chair of the medical committee for the 2022 San Diego GSAC Maccabi Games, a youth sporting event that involved nearly 2,000 teen athletes from across the United States and more than 70 delegations worldwide. And he's also a medical advisor for North America for the 2023 GACCA Maccabi Games in Israel. Dr. Neustadt is a frequent speaker at medical conferences, has written 4 books, dozens of articles on osteoporosis, and over 100 research reviews. Elsevier recognizes him as a top 10 cited author in the world for his article, Mitochondrial Dysfunction and Molecular Pathways of Disease. And his latest book is the Amazon bestseller, Fracture Proof Your Bones, a comprehensive guide to osteoporosis. So we are very excited to have him with us today. And with no delay, I'm going to pass it to Dr. Neustadt to talk to us about supporting women's bone health.
Thank you for the incredible introduction. I feel great hearing that. My body of work over the last 20 years, I think, has really led me to this point to be able to share what I've learned and hopefully help people not only to protect their bones and improve their bone health, but in doing so, when we look at an integrative approach, it's also helping other aspects of their health, cardiovascular health, neurological health, gastrointestinal health. It's all intertwined in an integrative fashion. I first want to thank the GW School of Medicine and the Women's Wellbeing Lecture Series for inviting me on to speak and share what I've learned. As I mentioned earlier, if you hadn't come on, I'm the proud parent of a new GW freshman in the Elliott School, so it's even more special for me to be doing this today. When I started in clinical practice 20 years ago, I never saw myself becoming an expert in this topic. But what happened was I had patients starting to come in with osteoporosis and with bone loss. And I thought I was doing a good job. I was doing what I was taught, and their bone density test results were improving. So I was happy and they were happy. My mother-in-law, who unfortunately just recently passed away a couple of weeks ago at the age of 94, she had osteoporosis at the time, and I was helping with her a little bit nutritionally with some recommendations, and she had her medical doctor, and she was taking Fosamax, and her bone density was going up. So she was happy, her physician was happy, I was happy, and then she tripped over a throw rug in her house and broke her hip. And I thought to myself, something is wrong with this picture, because by the objective measure off of which almost every clinician gauges our how we're doing, and almost every patient gauges how they're doing, she should have been protected. So I started diving into the research and really trying to understand what was going on and what the value and the limitations of the bone density tests were, and what else we could do to protect patients. And this presentation will share with you much of what I've learned over those decades of looking into this. So first of all, my disclosures, just so you know, I was mentioned in the introduction a bit. I am the founder of a dietary supplement company. I do have bone support products. My first product came out in 2007 because I couldn't find the dose of a specific nutrient called MK4. It's a form of vitamin K2 shown in clinical trials, not only to improve and maintain bone density, but to maintain strong bones, as indicated by fewer fractures in clinical trials. It didn't exist, and it didn't exist with calcium and vitamin D. So I went ahead and created the solution for my patients. So just so you know, as you're looking, hearing me speak, and I start talking about different nutrients, you'll understand that there are a lot of citations in here. I'm a big fan of education. So if anybody wants to dig deeper, confirm what I'm saying, edify what they've learned by looking up some of the studies, I have all the PDFs. You can contact me. I'd be happy to share any of the information with all of you. Live Full Out Media is the company through my wife and I created to publish our books. And there's my book. It lays out essentially how people can go through chapter by chapter and create a bone health plan that makes sense for them. So I tell people, when patients come to me, they usually have the diagnosis of osteoporosis already. They have a lone bone density test result, and they're scared, and there's a lot of anxiety around it, which I understand because it is a scary diagnosis. And what I tell them is to take a breath. It is serious, but it's not an emergency. There is time to educate yourself and put together a bone health plan, a comprehensive bone health plan that makes sense for you. So I go through chapter by chapter, helping people understand the research, giving them questions to ask their physicians to make sure they're getting the best recommendations, and how to create that plan for themselves and track results. So osteoporosis, or bone loss, is essentially a disease of imbalance. There are two major cells in bone responsible for bone health. One are the osteoblasts, and those build up new healthy bone. And the osteoclasts, they break down old, worn out bone. And it's a process called bone remodeling, where old bone is constantly being broken down and new bone is being built up. And when it's in balance, your bone is not losing bone density, it's not losing bone mass, and it's not gaining it. What happens with osteoporosis is the osteoclast, the destructive forces in the bone, are winning. And so you're getting bone loss. And you see on the right side, the healthy bone image versus the bone loss image down below. There are more holes in the bone. Now, when you look at this is the classic image of bone loss, where you've got this porous bone, these holes in the bone. And I want to point out that is a powerful image, and it does give you an idea that you are losing bone. But this is just the mineral component of bone. Bone is more than minerals. So the bone density test only measures the mineral component of bone, but bone is a tissue. All tissues are made up of different things. So you have the minerals, and then you have the bone matrix. And bone strength is a combination of the two. Bone quality, the quality of the bone, is often considered the bone matrix. And that is comprised of primarily bone collagen. So 90% of collagen in the bone is type 1 collagen, one specific type of collagen. There are about 16 types of collagen. Collagen is a protein. It's a structural protein in the body. It's in your skin. It surrounds all of your organs. It's in your bone, and it gives the scaffolding in bone on which the minerals bind. Healthy collagen is also flexible. and it's strong. Strand for strand, it's actually stronger than steel. If you take a chicken bone and you soak it in vinegar, you will demineralize the bone. You'll take all the minerals out of the bone, and what you're left with is the collagen, that extracellular matrix, and it's like a rubber chicken bone. You can bend it, you can run it over with a car, you can stomp on it, it will not break. But if you were to take all the collagen out of the bone and you're left with just the minerals, it's brittle like a column of chalk. And so it's that extracellular matrix, the collagen, that is so important for healthy bone. And the bone density test does not measure that. It only measures the mineral component of bone, which explains why the bone density test has limited value when it comes to actually predicting fractures. But bone also is more than just collagen. There are 180 to 200 different proteins in bone. It is highly protein dependent. And bone is much more than just structural. It does more than just allow us to stand upright and run and hug our loved ones and play with our kids and our grandkids. Bone produces our white blood cells and our red blood cells and our platelets. So it does a lot of important functions. Keeping it healthy is crucial for overall health. So what's the real risk with bone loss and osteoporosis? Well, it's fractures. A bone density test or any test result is just a number on a piece of paper or a number on a screen that you're looking at. Clinically, the number on the test is not the most important thing. It's whether or not you break a bone. Every 30 seconds, somewhere in the world, someone with osteoporosis is breaking a bone. And that debilitating chronic pain in the elderly is often caused because of fractures from osteoporosis. The older you get, the greater your risk. The median age for a hip fracture is about 82 years old, and the median age for vertebral fracture occurs in about their 70s. So advancing age is actually more predictive than a bone density test for your fracture risk. How does it compare to other diseases? Now, there is an osteoporosis awareness month, but there are no big campaigns like with breast cancer and people wearing pink ribbons or marathons, big fundraisers. But globally, the combined lifetime risk for a fracture with osteoporosis is about the same as a person's risk for cardiovascular disease. And it accounts for more time spent in the hospital than other diseases like diabetes and heart attacks and breast cancer. And actually, a woman's risk for osteoporosis is equal to her combined risk of breast, uterine, and ovarian cancer. If you have osteoporosis and you fracture a hip, there's up to a 36% chance that you're going to be dead within a year. Now, that risk for dying, is higher the older you get. But and then the numbers in the research, there's a range all the way down, 14 up to 36%. Most frequently, you'll hear 20%. But even with that 20%, the risk for dying from osteoporosis, from an osteoporosis fracture, is greater than a person's risk for dying from breast cancer. If you survive the first 90 days, fortunately, your risk for dying goes down. And in men, the risk is even higher. Similar to COVID and other diseases, comorbidities, if you have other conditions like emphysema or irritable bowel disease, congestive heart failure, atherosclerosis, dementia, all of those, any of these comorbidities increase somebody's risk from dying from a fracture. And in men, typically as we all age, the other diseases in men tend to be more severe than in women, which accounts for the increased mortality in men. If you happen to have breast cancer and osteoporosis, or breast cancer and you fracture a bone, there's 83% higher risk of somebody dying than a breast cancer patient without a fracture. So I like to start my talks out with all of these statistics to really drive home the seriousness of this. And I'm going to share with you also the holes out there and how it's being addressed, so that you, as clinicians, as healthcare providers, or if you're in the general public, can understand how you can do a better job of taking care of your patients or taking care of yourself. So the overall approach is quite simple. You identify the risks, you stop or minimize those risks. Anything possible that damages bones, you get rid of them, or minimize them. And it's not just damaging bone, it's also risk for falls. 95% of fractures occur because somebody falls. So anything we can do to reduce the risk of falling is naturally going to reduce somebody's fracture risk. And then you also increase things. What do? Well, you increase activities that improve bone density, that maintain bone strength, and that reduce fracture risk, that reduce your risk of falls. So let's look at the risks, what you want to minimize. So what you can control. So there are risk factors for bone loss and fractures. Some are what are called modifiable. That means you can control them. Others are non-modifiable. You can't control them, like your age. We can't change our age. And some are possibly modifiable, like medications. You may be able to modify your medications by decreasing a dose or changing to a safer medication. Or if you look at alternative ways or integrative ways of dealing with any health issues. I've also had patients be able to stop medications as well. About 75% of fractures happen in people older than 65. And as I said before, 95% happen because somebody falls. So one of the big effects there of hormone imbalances is the estrogen, testosterone, thyroid hormone, oxytocin, cortisol, melatonin, all of those. A lot of people, when it comes to postmenopausal osteoporosis, just think about estrogen, but other hormones are also involved. Oxytocin is sometimes referred to as the love hormone, and it's increased when people feel safe, when they're being touched, like with a massage, or they're being held by a loved one. And the osteoblasts, those bone building cells, produce their own oxytocin, and osteoclasts do not, but they can get osteotosin. They have receptors for osteotosin that's floating around in the bloodstream. They can then get oxytocin from the circulation. And multiple studies have shown that in association with the higher oxytocin, the lower the risk for osteoporosis. And in fact, in postmenopausal osteoporosis, research has shown is that women with postmenopausal osteoporosis have lower oxytocin than women without osteoporosis. So that's an example of really trying to think more holistically of things that we can do. And when it comes to oxytocin and what increases it, being in community, research has shown that people with a strong, healthy social network, they do things with friends, have lower all-cause mortality, which is from all causes, including osteoporosis. And they also, if they fracture, they have a faster recovery time. So thinking beyond estrogen is quite important. So who should get screened? The U.S. Preventative Services Task Force recommend that any women 65 years or older, or anybody postmenopausal younger than 65 should get screened. They don't recommend men should get screened, even though that 30% of hip fractures occur in men. So if your doctor is just, or clinicians are only following the U.S. PSTF guidelines, the official guidelines, they're missing a lot of patients who could be helped, because in fact, there are lots of medications that people are on, even women who are younger than 65, who are premenopausal, who are at high risk for bone loss, and they're being missed. They're not being screened. Other organizations like the Bone Health and Osteoporosis Foundation take a more nuanced approach. They do recommend men get screened over the age of 70. And then when other risk factors are there, like medications or diseases that cause osteoporosis, that they should be screened as well. Also, for any adult 50 years or older who breaks a bone, they should get a bone density test. I think that any woman around starting menopause, around perimenopause, I'd like to get a baseline bone density test so I can track results, because during menopause and for the 10 years after is the fastest rate of bone loss. Additionally, anybody taking a medication that can damage bone, I believe, should get tested. Now, this is important to know, because if you're not a healthcare provider watching this, you are likely going to have to request your own bone density test. You're going to have to ask your clinician about that. And the data bears that out. In fact, only 70% of eligible, or only 30% of eligible women and 4% of eligible men are getting tested with a bone density test. So we're missing 70% of women and 96% of men who are eligible just based on those criteria. The more narrow USPSTF criteria are being missed. And with Medicare population patients, that's 65 years and older, those are the highest risk age group. About 94.5% of patients are not getting screened. So as a whole, as a healthcare system, we're doing a very poor job of protecting our patients and screening patients. A bone density test result, however, should not be overemphasized. And unfortunately, that is almost exclusively what doctors and patients focus on. But we've known, and what I discovered when I started digging into the research, is that since the 1990s, we've known that a bone density test result predicts less than half of people who will break a bone. And in fact, the 2006 North American Menopause Society, their published position statement at the time stated correctly that fracture risk depends on factors largely other than bone mineral density. And then in 2008, an Annals of Internal Medicine article came out that quantified the value of that bone density test result even further. And what it found out is that a bone density test result only predicts 44% of women with osteoporosis who will break a bone and only 21% of men. So it's not very sensitive. It's not very specific. I do believe people should get them done because it's just one piece of a larger puzzle. It's something that we can track, and it's often the test result that starts the conversation, that gets people aware of what's going on with their bones and interested in doing something, because there are no symptoms with bone loss typically. The first symptom of bone loss usually is just somebody breaks a bone. It's a silent disease. And so this bone density test has that benefit of raising awareness, and it does have some important predictive value. But in the vein or on the topic of how it should not be overemphasized, a 2014 article came out showing that even the changes in the bone density tests that the FDA-approved medications create, so all FDA medications improve bone density tests, FDA medications for osteoporosis, but that change in bone density test result is not a good predictor of whether or not that drug is being effective at reducing fractures. Again, there are lots of limitations, and this nuanced approach to utilizing the bone density test in clinical practice is important for clinicians to understand. So let's talk briefly about estrogen. Bottom line is estrogen is very helpful for bone, not only for bone minerals, but estrogen is important for creating bone collagen. Estrogen is anti-inflammatory, and research has shown that supplementing with hormone replacement therapy with menopausal hormone replacement therapy is associated with a 26% reduction in overall fracture risk and a 28% reduction in hip fracture risk, which is the most dangerous type of fractures. Now, the benefits may decrease after the age 60 or if somebody stops, and the recommendation is to start when estrogen starts going down. That's the best time to start that hormone replacement. Progesterone also has a bone building effect. There are different routes of administration for estrogen with different safety profiles, whether it's transdermal, whether it's a troche, whether it's a cream or a patch, which are transdermal. So discussing this with your clinician, with somebody who is expert in hormone replacement therapy is really important to do it safely and effectively. But even in postmenopausal osteoporosis, there's a bias clinically that when a postmenopausal woman comes in with osteoporosis, it's estrogen and your estrogen's gone down and that's what's going on. But 30% of cases in postmenopausal osteoporosis are actually due to other causes, like medications. So I talked about falls. Let's talk a little bit more about that, because there are, again, modifiable and non-modifiable risk factors. We want to reduce the risk for falls. Briefly, when it comes to medications, it's important to understand that 95%, and I think this is tragic, 95% of elderly patients are prescribed a medication that increases their risk for falls. And so that's hopefully something that people will become more and more aware of, and the prescribing tendencies can change, so we can decrease that risk. So there are intrinsic factors, things going on maybe in the body, like sensory deficits. If somebody has diabetic peripheral neuropathy and they have a hard time feeling the ground when they walk, it creates an unsteady gait. An unsteady gait, whether it's from lack of muscle or imbalance from a neurological issue, that is the biggest risk, the number one risk for falls. That's the most predictive, most consistent predictor, is that gait or balance abnormalities. Environmental hazards, really important to fracture proof your home. So putting bars, grab bars in the bathrooms, next to the toilet to help you stand up, in the shower, getting in and out of the shower, getting rid of all throw rugs. I talked about my mother-in-law who tripped on one. That's common. Making sure areas where you're walking are well lit and full of and free of obstacles. There's no coffee table, for example, jutting into the walkway that somebody might be able to hit. Any loose steps or loose railings are fixed. Those are things that you can do to reduce somebody's risk. And hopefully clinicians are talking to their patients more and more about that. So are medications increasing your risk? There was a phenomenal study done a few years ago that looked at patients who were hospitalized for a fracture, what medications they were taking in the 4 months prior, and then what medications they were taking after they were discharged. What they found is that 76% of those patients, and these are elderly patients, 65 years or older, that they were taking medications that damage their bone, increase their risk for falling, and increase their risk for osteoporosis and fracture, 76%. But when they were discharged from the hospital, there was no decrease in that overall. So clinicians would recognize, maybe if there's a commonly understood medication that increases somebody's risk, they may take them off of that risk, or off of that medication, like prednisone, for example, or decrease it. But then they switch them to another medication that just does the same thing by different mechanisms, increases the risk for falls, fractures, or osteoporosis, like antidepressants, selective serotonin reuptake inhibitors, or selective or serotonin and norepinephrine reuptake inhibitors. Anything that artificially increases serotonin damages bone and increases the risk for fractures. And I'll review that literature and those statistics here in a moment. So this is the long list of medications, and we're learning more and more all the time. This list seems to get longer and longer as more data come in. But this presentation is recorded, so if you can't capture all this right now, I recommend you go back to the recording, you look at this slide, and you see, are you taking any of these medications? All of these medications either damage bone, increase fracture, or increase fall risk. With the blood pressure medications, and it's important to understand is that most of they work by increasing fall risk, typically when your blood pressure gets too low. So monitoring your blood pressure consistently if you're on one of these medications and adjusting the dose as necessary is sufficient to reduce your risk for falls. Other medications like the hypnotics for sleep, Xanax, Sonata, Ambien, those medications. What happens in general with medications as people get older, they don't metabolize the medications as effectively. So a dose that was fine at a younger age, the body can't break it down as fast typically as people get older. So what used to be a safe dose then becomes an unsafe dose. So making sure you're being tracked, making sure that those issues are being addressed, or you can get off the medication altogether and switch to a safer one, is really important. Polypharmacy, not just one medication, but when you're taking multiple medication, that increases your risk. And in fact, in people 40 to 79 years old in the US, 70% use at least one prescription medication, and over 60, 85% use at least one prescription. And when you're talking about taking at least 5 medications, 44% of men and 57% of women over 65 are taking 5 medications, and 12% are taking 10 or more. So this issue of polypharmacy, of drug-induced fractures and bone and osteoporosis and fall risk is really important. I can't emphasize this enough. In fact, 91% of patients in long-term care facilities take 5 or more medications. And those patients are even at higher risk for fractures and falls. So glucocorticoids. Fractures occurred at 30 to 50% of patients taking glucocorticoids like prednisone, dexamethasone, prednisolone, and an estimated 1 to 2% of the general population is on long-term glucocorticoid therapy. So be aware of that. You may not be able to reduce or go off your medication, but make sure that your doctor is aware you're having those discussions, because you can initiate then treatment for the glucocorticoid-induced osteoporosis to help protect you if you're not able to go off of that medication. And the antidepressants. So, Prozac, Lexapro, those types of medications, things that increase serotonin. There are serotonin receptors on bone. And when serotonin is in balance, in fact, over 90% of serotonin is not even produced in the brain. It's one of our happy chemicals. It's produced in your intestines in a type of cell called an enterochromaffin cell, and it circulates in platelets and doesn't cross through the blood-brain barrier. It doesn't actually get into your brain. There are many different types of serotonin receptors in the body. Bone has serotonin receptors, and when serotonin gets too high, what it does is it activates osteoclasts. It decreases osteoblasts, so it increases the bone breakdown. 24, almost 25% of women age 60 or older took an antidepressant in 2018, and that was before the pandemic. So I've got to believe that that's only gone up since then. And these categories of antidepressants are the most commonly prescribed. There have been multiple reviews and meta-analyses done on these medications. And what they found is that even less than 1 year of taking it increases fracture risk by about 3%, or for every 85 people taking it, you get 1 additional fracture. People tend to take these medications for years. What they found is that if you're taking it for 1 to 5 years, for every 19 patients taking the medication, the research indicates that we would expect 1 of those to break a bone. And a 10-year Canadian study also confirmed that the SNRI medications also increase fracture risk. Now that's important because my American colleagues, I hear often, they say, well, it's only the SSRIs and not the SNRIs. And I've had to send the studies to patients to send to their clinicians to educate them and teach them that no, actually, the SNRIs also come with risks. Acid blocking medication. So proton pump inhibitors specifically, 50% of those are just written for acid reflux or GERD, gastroesophageal reflux disorder or disease. In 2006, we've known since, I mean, how long ago is that? Almost 20 years, 18 years, that it increases fracture risk. These medications were never approved by the FDA for long-term use, and yet people are taking them for years. They're now available over the counter. So taking it for just 1 year, more than 1 year, is associated with an 85% increased risk for fractures. And for patients who are taking it for acid reflux, their risk for fracture was even higher. The FDA warned about this issue in 2010. An FDA warning letter went out. And yet many clinicians aren't aware of this. A quick, brief caveat, sort of an aside on this. The osteoporosis medications, have been approved by the FDA mostly for the treatment of postmenopausal osteoporosis. Bone loss from postmenopausal osteoporosis is caused by specific mechanisms, specific things going on in the body. Osteoporosis or bone loss caused by other things like acid blocking medications, that bone loss, the mechanisms that are creating that bone loss are different than in postmental osteoporosis. And so the assumption clinically has been for many years is that, well, if I give a medication for a patient for postmenopausal osteoporosis, and a medication that's approved for osteoporosis, then and they have osteoporosis caused by a medication like an acid blocker, then I'm just going to give that same medication. So the assumption is if it's good for postmenopausal osteoporosis, it's good in these other situations as well. Well, researchers decided to study that because that's an assumption. And what they found out is that when you actually give an oral bisphosphonate like Fosamax along with a proton pump inhibitor, the person's risk for fracture was increased beyond if they were just taking the acid blocking medication alone. So that nuanced understanding of the medications is also important. I discuss that in my book to give patients questions to ask their doctors so they make sure they're getting safe and effective recommendations. Sleep. One of the things that's not commonly talked about when it comes to bone loss and osteoporosis, but is important, is sleep. Not only does it increase your risk for dementia and cardiovascular disease and diabetes and hypertension when you don't get enough sleep, but research now shows that it increases your risk for osteoporosis as well. So sleeping less than 5 hours a night is associated with a 63% risk of osteoporosis of the hip and a 28% increase of osteoporosis in the spine. So really we want to get about 7 to 8 hours sleep a night. There are obviously those medications, those hypnotics that are used for sleep conventionally can help you sleep, but they also come with the risk of increasing fall risk. So there are holistic ways that you can approach sleep. There are dietary supplements that can promote healthy sleep. There are lifestyle factors like going to bed at a consistent bedtime. Fitbit that does this activity tracking software, hardware. They had billions of data points from users, and they looked at what was the most consistent predictor of healthy sleep in their users. And what they found is that it was going to bed at a consistent time. That was the most predictive for healthy sleep. Now, as we age, there can be other things going on and other things that you might need to deal with. But going to bed at a consistent time, hopefully, is an easy thing that people can start to implement. Diet, crucially important. So the standard American diet is a disease-promoting diet. It's high in pro-inflammatory foods. It's high in processed foods. And in fact, 71% of packaged foods in the US are what are called ultra processed, not just processed. So for example, technically, pickles are processed. It's fermented cucumbers, right? That's a processed food, but that's a healthy food. Fermented foods are healthy. They're healthy for the gut microbiome. They have good nutritional value. Ultra processed foods are foods that are packaged foods with industrially created ingredients that have all of essentially the whole foods taken out, stripped down into their components, and recombined with artificial colors and artificial flavors and other ingredients that have no nutritional value. And we now know actually disrupts our hormones and our biochemistry. And in fact, about 60% of calories in the US are from ultra processed foods. A study came out not that long ago showing that consuming that much increases the risk by 80% of osteoporosis. And you can actually consume a healthy diet according to the USDA dietary guidelines while still getting the majority of your calories from UPF. So just following the dietary guidelines is not enough. You really need to understand what is the dietary pattern, overall pattern, not just looking at calories and how much sugar you should avoid or not get, but what is the overall healthy dietary pattern? Well, what the research has shown over decades, 50, 60, 70 years, is the Mediterranean diet is the healthiest. Women who adhere to that, what is essentially a plant-forward whole foods diet, who adhere to that more strictly have lower osteoporosis and fracture risk. It's associated with over 20% reduction in hip fracture risk, and also associated with healthier lifestyle, greater activity levels, fewer toxic habits, and it has its own food pyramid. So being physically active is part of that, enjoying meals with others. I discussed that social aspect of health. Look, take lots of fruits and vegetables. At the very top, meats and sweets, less often, maybe a couple times a month, not as often as in the US diet. So exploring this dietary pattern and transitioning into that is important if you're not already eating that way. What about vegans and vegetarians? We know that eating plants are healthy. Plants are associated with lots of beneficial health outcomes, including reduced osteoporosis risk. But research and looking at vegan and vegetarian diets show that they are actually at higher risk for osteoporosis. And the speculation in the literature is that because oftentimes they're not getting enough protein, it's that protein component that I talked about that is the missing component. So how much protein do you need? The minimum protein by the US recommendations is too low as we age to maintain healthy bone and muscle mass. And in fact, a lot of adults aren't even getting the minimum amount of protein recommended by the USRDA. And in general, people are losing 3 to 5% of their muscle every year, which increases your risk for falls. And 80-year-old has about up to 25% less skeletal muscle than they did when they were younger. So the research is clear that higher protein is healthier when it comes to muscle. The research, a recent study came out that even the oldest participants in the study were 85 years old. In all age groups, even up to 85 years old, getting sufficient protein, which was about 1.3 grams or 1.2 grams of protein per kilogram body weight per day, plus resistance exercise, they increase their muscle size, their thigh muscle size, and their strength. So my recommendation is to get about 1.3 grams of protein per kilogram body weight, or if you take your body weight in pounds and you just multiplied it by 0.59 or 0.6, it's an estimate, that's about the minimum of the number of grams of protein you should be eating a day. And it can be challenging with diet sometimes. So that's where supplements come in. You can supplement with a protein powder if you need to. I created a system that I've trained, help thousands of people transition into eating healthier. And it's just 3 steps. It's really focusing on just consuming 2 things, plants and protein. It's those plants that are going to have those vitamins, those minerals, those other phytonutrients that our body and our biochemistry needs. And also fiber. The fiber helps regulate blood sugar. It feeds our gut microbiome to have healthier microbiome, which is important for osteoporosis and many other health conditions. And so consuming 30 grams of total dietary fiber from whole foods, and then whatever your protein requirement is. And then these are my 3 steps. There's a link there. There's an article. It's also in my book, but the article there, you can download handouts to help you transition into eating this way over, 4, 6 weeks, whatever's comfortable with you. The goal is to develop a new eating habit. So then it just becomes part of your lifestyle and your daily habits. But to get to that point, people need to focus on it and learn and relearn how to eat. So exercise, not all exercises are safe. There's only been one study that looked at fracture outcomes in osteoporosis. And what it found out is that flexion exercises, sit-ups, for example, where you're bending forward, increase people's fracture risk. So extensions are better. Just going and pumping iron at the gym or doing Pilates or yoga without modifying it and working with somebody who is an expert in this can increase your risk for fractures. So I really caution people against that. You don't have to go to the gym. Even just walking alone has been shown to reduce all-cause mortality by 50 to 70%. That's from all causes, including osteoporosis. And it doesn't have to be 10,000 steps a day. Like, that's a myth. Just 7,000 to 7,500 steps per day, on average. Moderate to physical exercise, also associated with reduced fracture risk. Moderate exercise, if you don't know what that means, it means exercising in a way where you can still have a conversation, but you're a little winded and it's a little strained to have the conversation. That's called the talk test. Vigorous exercise is when you're exercising so vigorously that you're winded, you can't have a conversation. And mild exercise means you can talk normally just like I am and you're not winded at all. So that's a way you can sort of gauge yourself and your intensity. So let's talk about individual nutrients in the time that we've got left. The way that I evaluate the research, the way that I make my decisions, both personally and clinically, is I want to know which nutrients have been shown not only to stabilize or improve bone density. That's one piece of the puzzle, but most importantly, which nutrients have been shown in clinical trials and epidemiological research to reduce fractures, to maintain strong bones. There are only 4 nutrients that reach those requirements, that meet those requirements. Calcium and vitamin D reduces fractures by about 18 to 23% in the research. Ideally, you're getting your calcium from diet. I'm a fan of testing vitamin D levels and getting to the proper level. For bone health, the test result is 30 to 44 nanograms per milliliter. There's a slide on that, is associated with the optimal fracture reduction. Now, if you're looking for immune support and the immune benefits for vitamin D, many clinicians in the research support much higher, 50, 60, 70 on a test result. But for bones, you're looking at lower than that, 30 to 44 when it comes to fracture reduction. MK4 is a specific form of vitamin K2. There are 2 forms you'll see in dietary supplements, MK7 and MK4. Only the MK4 form has been shown to not only improve bone density, but maintain strong bones, as indicated by over 70% fewer fractures in clinical trials. MK7, in contrast, has only been shown to reduce how fast somebody loses bone. It just slows down the bone loss, not reverse it. And it's never been shown to reduce fractures in any clinical trials. Now, it's impossible to get the 45 milligrams of MK4 used in clinical trials by food. You have to get it. That's where supplementation is really important. And strontium was approved as a medication in Europe. I'm going to mention that. I'm not a fan of strontium because what the European data showed is that with the medication, for every 1 fracture that was prevented, the medicine caused a thromboembolism, a blood clot that could create problems with breathing in the lungs, or a heart attack or a stroke. So for every 1 patient that was helped, they were harming another patient. And in fact, that medication was removed from the market for a while in Europe. And it's not available in the US in that form anyways. It's just as a dietary supplement. There are no clinical trials on the dietary supplement showing improved bone density or reduced fractures. Also, if you take strontium, it creates a false bone density test result. So just be aware of that. Despite the limitations of the bone density test, I want the result to be accurate. And the bone density test results are false because it's a mineral. And so as the x-rays from the DEXA scan bounce off the bone, it changes how the machine interprets that, and that can't correct for that. And so the bone density test results are false. And then there's some other nutrients here. I'll address those briefly. So here's the stuff with calcium. Basically, a lot of people are mega dosing on calcium. They're getting too much calcium. They're taking routinely 1,000, 1,200 milligrams of calcium as a dietary supplement. Absolutely not necessary. And in fact, may start getting them into a dangerous range of taking too much calcium. The current position statement from the Bone Health and Osteoporosis Foundation and the American Society for Preventive Cardiology is that it should not exceed 2,000 to 2,500 milligrams per day from all sources, diet and dietary supplements. And the average American woman gets 800 milligrams of calcium in her diet. So taking 1,200 milligrams as a supplement is getting you into that dangerous range. So most women probably will do best just taking about maybe 400 milligrams. And in terms of the form of calcium, calcium citrate is my preferred form because it's better absorbed than the calcium carbonate, especially when people have low stomach acid, and people tend to get lower stomach acid as they get older. Vitamin D, I talked about vitamin D. Safety, considered safe up to dosing of 10,000 international units a day. K1, consuming vitamin K, phyloquinone, in your diet in green leafy vegetables is associated with 22% reduction in fracture risk. There are no clinical trials showing that supplementing with it is similar to magnesium. There are data showing that dietary or that low magnesium in the blood is associated with osteoporosis risk, but supplementing with magnesium as a dietary supplement has never been shown to reduce fractures. So better to get these things from food. And there's some, even just increasing your amount of green leafy vegetables or vitamin K1 intake a little bit, 50 micrograms a day, you can decrease your fracture risk by 3%, or it's associated with a 3% decrease in fracture risk. So I talked about MK4, vitamin K2 as MK4 and MK7. The MK4 has been approved by the Japanese Ministry of Health since 1995 for bone health. Clinical trials on MK4, 45 milligrams or even higher, or 45 milligrams for bone loss, have been done in all of these cases. Even people taking prednisone, glucocorticoids, shown to stop the bone loss from that medication. Leuprolide, which is an anti-androgen deprivation therapy, also shown to stop bone loss, and other conditions, including postmenopausal osteoporosis, shown to improve bone density and reduce fractures. There's a lot of misinterpretation and confusion out there in the research about vitamin K. Many researchers, even in published studies, don't even say what form of vitamin K they used in their clinical trial. I've had to email the researchers and ask them for clarification before. And data is getting misinterpreted even by national associations. So the North American Menopause Society 2021 position statements use this meta-analysis here that I'm showing to state that people should not use, clinicians should not supplement with vitamin K. But even this meta-analysis, they concluded saying that their results cannot be confirmatory about any specific form of vitamin K. They sort of grouped together all studies with all forms of vitamin K and even say this can't confirm one way or the other if specific forms work. And yet the North American Menopause Society then just summarily dismissed all types of vitamin K because of this. So they misinterpreted this research because there are in fact 3 meta-analyses of clinical trials of MK4, 45 milligrams a day for bone health. All 3 of them showed fracture reduction, improvement in bone density, maintenance of bone density, and more importantly, reduction in fractures. In one, all non-vertebral fractures reduced by 76%. Safe, considered safe. The only contraindication if somebody's taking the medication warfarin. I talked about strontium, so I'm not going to belabor that. Melatonin, I talked about melatonin receptors. So there's a clinical trial, women with osteopenia, taking 3 milligrams per day at nighttime of melatonin, increased bone density. So that may be a good, something good for people to try. Magnesium, I want to mention this because it's a common misconception that you have to have magnesium as a dietary supplement. There's no evidence showing that it reduces fractures. And in fact, you can see the conclusions here are multiple studies here that people can look up. And there are no prospective controlled clinical trials showing that it reduces fractures. Collagen. I mentioned collagen as a structural protein. What we know is that taking collagen as a dietary supplement has been shown to reduce a blood marker called CTX that is an indication of collagen destruction in the bone. And it's also been shown to improve bone density. There are no outcome studies with collagen in fractures, but it has been shown to improve bone density, supplementing with collagen. So here are a summary of my recommendations there. It's everything that I kind of went over. And this is my last slide. I know we're kind of running towards the top of the hour here, so I want to make sure, hopefully we've got some time for questions. And if anybody wants to see additional resources or learn more, they can go to the mbihealth.com website. In addition, based on all of this research, I just want to mention again, I did create the products for this that have the clinical doses in them with guarantees of efficacy. And you can look at those on my website and learn more with any of the studies and research that I presented.
Thank you so much, Dr. Neustadt. It was amazing and very informative lecture, and we have tons of questions. So unfortunately, with just a few minutes left before we adjourn, we wouldn't get to all of them. But here are a few I want to focus on. So one, where can I get a micro MRI that measures quality of bone versus DEXA that measures bone, quality?
So that's a great question. So you'd have to talk to your doctor. I mean, a radiology department should be able to give you an MRI. But the important question to ask, and I really encourage anybody who's getting any test done to ask the question. And hearing about bone quality is great. That sounds better. Oh, bone quality, therefore it must be a better test. But the question should be asked, has this test been shown to predict fractures better than a bone density test? What we know with MRIs and CT scans is their predictive value for fractures. Everything is compared against in studies against the bone density test, the DEXA scan, because that's the gold standard. MRI, CT scan, nothing has been shown to be more predictive of fractures than a bone density scan, a DEXA scan. That is essentially they can be equivalent, but not better, is what the research show. There is an emerging technology based on ultrasound that there's only one validation study. It's the technology is coming out of Italy. It's called an EchoLight, that hopefully additional studies will validate it more, and it will become more widely available, and insurance will start to cover it. But they provide what's called a fracture score. And in the validation study, it was more predictive than a bone density test. And also, you don't have the radiation from the bone density test, a DEXA test. So I think that's a space to watch. But you could ask your physician for referral to a radiology department for the MRI if you'd like one.
Great. I think we have time for one more. And there was another one on naps as a possible compensatory mechanism to perhaps reduce risk of fractures. What are your thoughts on that?
Taking naps?
Yeah, would taking naps compensate for a shorter night of sleep?
I don't know. I'm a big fan of naps. I love taking naps, and naps are healthy. I don't know the data on that, so I'm sorry I can't speak to that.
All right, very well. Well, I think I can get one more. Thoughts on vibration machines?
They're
And
great. They've been shown to improve bone density. No fracture outcomes, but they improve balance and bone density. So I think they're great.
all right. And then there was an interesting question on inflatables as an emerging kind of protective devices against fractures. And I think this is kind of studies not yet on the market, including Chicago Branch Parkinson's Foundation. So inflatable vests, what do you
Well, it's
think
kind of
about
like wrapping yourself in bubble wrap. If you
that?
fall, it'll maybe protect you from fracturing. I don't know.
All right. Well, I think we are at the end of our time, and I want to thank you so much for sharing it with us.
Thank you. And
And
I know we didn't get to all the questions. So if people have additional questions, please feel free to reach out to me. My email is on the first slide, or you can fill out the contact form at nbihealth.com, and those will all be forwarded to me. I'd be happy to speak with anybody on the phone or email back and forth, provide you what information you need to make better decisions.
and everyone, I know you were asking questions about slides. It's our intent to share slides with everybody after the event, so you will get a copy. All right. Well, thank you for being with us, and enjoy the rest of your day, everyone.
Thank you.